Hello, everyone. Welcome to the Preemie Health Talks. I'm Fabiana Baquin, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preemie Health Talks is the first international live series that CPBF is hosting in 2021. These educational sessions are in collaboration with the Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, the Canadian Neonatal Network, the European Foundation for the Care of Newborn Infants, EFCNI, GLANCE, the Global Alliance of Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to empower families of premature babies every step of the way through support and education. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their babies. For this Preemie Health Talks, we brought experts from all over the world and Canada, and we'll be diving deep into topics affecting preemie health, from breastfeeding to parental mental health during the pandemic, from the importance of kangaroo care to the best practices to protect your baby's skin. If you need closed captioning, you can watch it live from our YouTube channel and enable closed captioning on the screen. I want to thank our sponsors, Medela, Water Wipes, and Prolacta Bioscience. And if you have any comments and questions, please ask your questions on the comments below and your perspectives and your stories. We'd love to hear from you. And today you have three presentations, one with Dr. Esther Rai on the importance of breast milk, followed by Karen Lasby talking about feeding after discharge, and also Dr. Takeshi Arimitsu on the chances and challenges of tiny babies. And for our first presentation, I have here with me, joining live from Hamilton, Ontario, Dr. Esther Rai. She's going to talk about the liquid gold, the importance of breast milk in the neonatal intensive care unit. We'll discuss the importance of breast milk in the NICU, explain the benefits of breast milk, and talk about strategies to improve mother's milk supply. We also talk about the use of donor breast milk and the different fortifiers that are added to breast milk to provide appropriate nutrition and achieve adequate growth for preterm babies. Dr. Esther Rai is an assistant professor in the Department of Pediatrics, Division of Neonatology at McMaster University in Hamilton, Ontario. Dr. Rai's academic interest lies in quality improvement in neonatal care, with a focus in QI related to neonatal growth and nutrition, as well as neonatal outreach education and nosocomial infection prevention. She has implemented numerous evidence-based guidelines and chairs several quality improvement committees, including the Neonatal Nutrition Committee. Dr. Rai is the site investigator for EPIC, Evidence-Based Practice for Improving Quality, which focuses on implementing evidence-based best practices in NICUs across Canada to improve quality of care and outcomes. Dr. Rai, thank you so much for joining us here today.
Good afternoon. Thank you for having me.
Dr. Rai, I know you have a presentation to share with us. I will let you share your screen. And I'm just reminding everybody watching us live from YouTube or Facebook, we have a Q&A at the end of her session, and you can send your questions and comments, and we're going to address all of them at the end. So here you go. Dr. Rai, you have the screen.
All right. You can see my presentation?
Yes.
Excellent. Okay, thank you so much for having me, Fabiana. It's really a pleasure to be here. There's just a host of great speakers lined up for today and the rest of the week. So it's my pleasure to start this week off. And I'm really going to talk about, maybe just lay some groundwork, kind of the basics around the importance of breast milk in the NICU and why we refer to it as liquid gold. There we go. So we're going to go through a few different topics. So first, I'm going to talk about why breast milk is so important. We're going to talk a little bit about donor breast milk, the similarities and differences in that. And then we're going to get into some strategies to really improve mom's milk supply. And then lastly, we're going to finish off by talking about the different fortifiers and why we need to fortify human milk. So what is in breast milk? So breast milk contains macronutrients. So those are fat, protein, and carbohydrates. It contains mineral and vitamins, and particularly calcium and phosphorus, which are really important in developing your baby's bones. But what makes it so special is really the bioactive component. So the immunoprotective factors that include antibodies, macrophages, lactoferrin, and all of these play an important role in protecting your babies from infections, and it supports the development of the different organ systems. It also contains growth factors that stimulate the maturation of the intestines, and it improves the ability to digest and then absorb the nutrients that the babies take in. And then lastly, it contains healthy bacteria, such as lactobacillus, which are transferred from mom's milk into the baby through breast milk. And we're going to talk a little bit more about bacteria. So the gut microbiome, it really has an extensive physiologic influence on multiple organ systems. So their development, the maturation, and the function of the different organ systems in the baby's body. So not only does it interact, or does it work to lay down your baby's foundation for their immune system, but it also interacts with the baby's lungs and the baby's brain, and it impacts the development and the maturation of those organ systems as well. So there's different factors that impact your baby's microbiome, and your microbiome is really established in the first 1,000 days of life, and it's affected by, like I said, maternal factors such as stress or infection and obesity that have an impact on the bacteria that end up living in your baby's intestines. And then there is baby factors as well. So baby's a mode of delivery, so whether the baby was delivered via vaginal delivery or a C-section, whether the baby required antibiotics for a period of time after delivery, and then importantly, what the baby eats. So whether the baby receives breast milk or whether the baby receives formula. So just to describe this in a little bit more detail here in this little table, you can see that in term neonates, baby's microbiome is mostly consists of healthy bacteria, lactobacillus and bifidobacterium. Preterm babies have different bacteria listed there, and I won't go through them, but you can tell that they are different. And breastfed babies also have that majority of lactobacillus and bifidobacterium that live in their gut. Again, those are the healthy bacteria. Whereas formula-fed babies have a different microbiome made up of different bacteria. Vaginally delivered babies tend to have a predominance of lactobacillus, again, that good bacteria living in their gut. And then C-section babies, again, they have a different makeup of their microbiome. So the intake of breast milk really sets the stage for the development of your baby's microbiome. Because it's been demonstrated in multiple trials and studies that a healthy microbiome that's made up mostly of lactobacillus and bifidobacterium can be supplemented through probiotic supplementations, it reduces the risk of necrotizing enterocolitis, death, and other important outcomes in the intensive care unit. And so most Canadian centers now supplement with probiotics, mostly lactobacillus and bifidobacterium, or a combination of those two bacteria. So just to go back a little bit to the composition of mother's breast milk itself, the composition is really highly variable and it's dynamic. So where formula products have a really consistent composition, breast milk varies in the composition, and it's really just nature's way of helping mom provide exactly what the baby needs during the different stages after birth and as her baby grows and develops. So milk of moms who deliver prematurely have a higher content of protein and fat than the milk of moms who deliver at term. The protein content is initially high, and then it decreases as weeks of lactation go by. While fat content, it slightly increases over the course of weeks. Even so, there's differences between the foremilk and hind milk in moms as well. So the milk that comes out first is called the foremilk, and the milk that's pumped near the end of a pump is called the hind milk. And that really has a higher fat content. So even within the same sample, there's variation in the amount of breast milk. just to go back up here for a second, there's also differences depending on, like I said, when a baby is born prematurely, that milk tends to have higher protein content and fat content, and that's really Mother's Nature's way of trying to compensate for the premature birth and trying to provide the higher nutrient requirements for mom's baby. Initially, after the baby is first born, mom's milk consists it's called colostrum in the first day or even 2 days of life, where you can see the picture on the left here, that yellowish milk. And that's really high in all of those important immune protective factors, antibodies and things, as well as high in protein. And then as mom transitions to more mature milk, that protein content ends up gradually decreasing over time. So now that we've talked about the differences in the breast milk, I'm going to talk a little bit about what the benefits of human milk are. So compared with formula, human milk reduce many of the fear complications of prematurity. So we see lower rates of infection, lower rates of necrotizing enterocolitis, lower rates of retinopathy of prematurity, bronchopulmonary dysplasia, and we see fewer rates of rehospitalizations in the first year of life as well. And we see improved neurodevelopmental outcomes when we see these beautiful babies back, at that check-in time around 24 months. Long-term benefits of human milk also exist, so it's not just short-term, but we see benefits even into adolescence and beyond. So children who, or babies who were mostly breastfed, they tend to have lower rates of metabolic syndrome when they are in adolescence. They tend to have lower blood pressures. They tend to have lower low-density lipoprotein or cholesterol levels, and they have less insulin resistance. And studies over time, I mean, there's been so many studies and randomized controlled trials that have looked at the impact of breast milk on outcomes, and it's really become clear that there's a dose-response relationship. So even small amounts of breast milk provide benefits, and the more of it you're able to provide for your baby, the higher the impact of the breast milk is, and the more beneficial or the better the outcomes are. So what about donor milk? So donor milk is pasteurized to inactivate viral and bacterial agents. And in doing so, of course, also the good bacteria are killed. And the second important piece, or the second important impact of pasteurization on milk, is that it reduces the important bioactive components that we talked about earlier. So they have lower antibody content and growth factors. Donor milk also has a lower protein content, and it's partially due to the pasteurization process, but it's also because milk that's donated to milk banks tends to be donated by either by term moms. So if you remember earlier, I was talking about the variation in protein content of breast milk, and as moms go through their lactation journey, the protein content gradually decreases. So by the time moms have enough milk to start donating to milk banks, they tend to be at a later stage. And so there's less protein in that donated milk. So that's the second reason why, generally speaking, donor milk has a lower protein content. And then lastly, donor milk is lower in fat content, and that's really due to the freeze-thaw cycles that happen as we process donor milk, and it's changed from different containers where the fat tends to stick to the plastic containers and therefore is essentially taken out of the milk. So does donor milk have the same beneficial effects? And most of this information on these slides comes from a really great review article by Paula Meyer's group that talks about donor milk. And when we compare donor milk strictly to babies who receive formula or mom's own milk, it is clear that donor milk-fed babies, they simply don't grow as well, and they tend to require more fortification, and that's likely secondary to that lower protein content. The benefits of donor milk are still present, perhaps to a lesser degree, and we can definitely see when we compare strictly formula-fed babies to donor milk-fed babies, there is a decreased risk of necrotizing enterocolitis. And Dr. Meyer talks about how it's likely not so much the makeup of the donor milk itself or the properties of the donor milk itself, but rather just the avoidance of formula that leads to these reductions of adverse outcomes. So now we've talked a lot about breast milk and why it's so important. And I want to kind of shift our attention now to how can we optimize mom's own milk supply. And really the key here is early discussion about mom's intent to breastfeed or to provide her own milk. And we want to obviously do that in a very non-judgmental approach, especially when moms initially express their wishes to formula feed the baby. And in those circumstances, it really is up to us as healthcare providers to explore some barriers and or fears about her hesitation to initiate or provide her own breast milk. So some moms might find that they don't want to provide breast milk because they're taking medications and they're worried about that medication being passed on through her breast milk and to the baby and having an impact on the baby in a negative way. And so just talking through some of those hesitations oftentimes will provide mom with enough information to make an informed consent to and decide to provide her own milk. Similarly, some moms might think that it's going to hurt. So there's counseling and education that we can do and making sure that we provide her with all of the information that's required so that she can make an informed consent about providing her own milk. And 99% of the time, those conversations are very helpful and we're able to get mom on the same page as us. So as we have these discussions, it's really important to put an emphasis on what mom can do to help her baby avoid the complications that we often encounter in prematurity and to stay as healthy as possible through the NICU course and then obviously beyond. And really, this is a way for her to gain some control back over a situation where she's probably felt like she's lost complete control over the situation, given that she's just had a premature baby. She's going through an extremely stressful time in her life. And so this really gives back that sense of control a little bit. As I mentioned, of course, we have to explain that breast milk reduces the chances of infections and other complications of prematurity. And this is her way of being able to help her baby with that. It's really important to set very clear expectations of how we can optimize mom's milk supply. And the key here is really being consistent in messaging, which is really crucial. Sometimes we still occasionally hear, for example, if a mom's delivered at 9 p.m. at night, we touch base with mom first thing in the morning and ask her, have you been able to get any milk yet? And the response occasionally still is, I was told just to rest overnight. I had a rough delivery. And so we've really missed an opportunity in those circumstances where mom could have started pumping early, and that unfortunately was missed. So consistent messaging and knowledge of our frontline healthcare staff is really, really important so that we're all on the same page of what needs to happen in order for that milk supply to be optimal. So key things here are the early initiation. And really, when I say early, I mean ideally within the first hour. Studies have shown that if you, for moms who initiate in that first hour, their milk supply is significantly higher at 7 days than moms who started after that first hour. And that effect is really sustained to, 6 weeks postpartum and beyond. Secondly, the frequency is very important. So we want mom to pump at least every 2 to 3 hours for 15 minutes, a minimum of 8 times a day. She really shouldn't go more than ideally 4 hours overnight without pumping. And we want to make sure that she's using, ideally, not hand expression, but a hospital-grade double pump to really get the most out of that. So the second important piece is to have support in place for her. So early and continued lactation consultant support is really important. Lactation consultants are able to make sure that moms have the right supplies, the labels, the pump supplies, the shields, all of those things. And they're able to provide emotional support, of course, because this is a scary time for her. Providing that emotional piece that she has one touch-based person that she can go to is really, really important and helpful. Really, as I mentioned, the expectations are really important to lay out and explaining to mom that, you might not get anything the first few times that you pump. even if you see a few drops. It might not seem like much, but it is a lot, and we do want those few drops even brought over to the NICU, and ideally you or the nurse will put that milk into your baby's mouth, because it contains a lot of important protective factors like we talked about earlier. Being able to set mom up with some targets is really important too, just so she herself can track how she's doing as the days progress in the first 2 weeks. And it also allows us to kind of track how she's doing. Are there any problems, so that we can identify those early, and a lactation consultant is able to make changes to her pumping plan or medications if need be. We know that the first 2 weeks of milk expression are critically important in establishing and then maintaining that milk supply. So this is why we're so focused on that right from the get-go, as stressful as that time may be. It is a very heavy workload to pump, and you feel like all you do is eat, pump, sleep, and then pump again. So partner and support person involvement is really important and can alleviate some of those stresses from mom through just even helping with the cleaning of the kits after mom is done pumping. So that's important if a person is available to have them involved in really doing hands-on things to help mom out. I just want to spend a little bit of time talking about, how do we cope when, or what do we say or shouldn't say when milk supply isn't quite enough? I mean, there's circumstances where moms, they do everything right. They follow our advice, but they simply don't quite get enough milk to support their babies. And sometimes that's secondary to, oftentimes actually, it's because there's risk factors involved that place her at risk for not being able to provide enough milk. So perhaps she has a history of infertility, perhaps she's overweight or obese, perhaps she had pregnancy-induced hypertension, she may have had excessive blood loss at the time of delivery, she may have delivered via C-section, in which cases we know milk supply may not be as good as when a mom delivers vaginally. So, when we're speaking to healthcare providers, for us on rounds, it's important to say, we avoid saying things like, well, there isn't enough milk, we're using donor milk, because if mom's at bedside and she's part of those conversations, it might sound like a failure, or she might feel that way. And so just being aware of how we talk about that on rounds is important from a healthcare provider perspective. So if breast milk is liquid gold, then why do we add a fortifier? So we're going to switch gears a little bit and talk about fortification. So premature babies, they have a greater nutritional intake needs in the neonatal period than any other time in their life. So one of the main reason, there's two reasons. One is, but the most important one is probably to support appropriate growth. So premature babies, they have much faster growth rates than babies who are born at term. So when you look at this little table here, you can see that babies around 23 to 27 weeks of gestational age in utero, so as fetuses, gain about 21 grams per kilo per day. That drops to almost half by the time they're 37 weeks. So you can imagine how fast they grow, and and in order to support that growth, how much nutritional support they actually need. On top of that, they're not inside of their mom's tummies anymore, and so they may have medical conditions that increase that metabolic demand even further. And then lastly, they have immaturity of the intestines, so they don't quite have the same ability to digest and absorb nutrients than a term baby might. So all of those things combined lead to a higher need for nutritional intake, and we do that through adding fortification. The second important part, aside from growth, is the need for minerals. So calcium and phosphorus are incredibly important, and they tend to be laid down or built up in babies in that third trimester. So it's really important that we supplement with that in order for their skeletal system or their bones to grow nice and strong. So fortifier, most commonly used fortifiers are multi-nutrient fortifiers, and they contain, like I said, varying amounts of protein, energy, minerals, trace elements, vitamins, and electrolytes. But there's also single macronutrient fortifiers available. So for example, babies who receive mostly donor milk, that is relatively low in protein content, we can add just simple protein fortifier to those donor milk feeds if need be. And then the types of fortifiers that are available, the protein can either come from a bovine source or human source. The bovine source or cow source, it can either come as a powder fortifier, which essentially means that it comes from intact bovine protein, or contains intact bovine protein, I should say. And then there's also a liquid fortifier that's available, which contains extensively hydrolyzed bovine protein. And so that essentially means that the protein is broken down into smaller pieces. There's also a fortifier available that is obtained from donor milk. So the bovine powder has very little displacement of mother's own milk. So that's definitely a pro. The osmolality, or the concentration of the particles in the breast milk, is not a concern. So it's just raises the osmolality by a little bit compared to mom's breast milk without any fortification. The cons are that, it does contain intact bovine protein, and the powder form is not sterile. I'm not so sure how big of a concern that is, given that mom's milk is also not sterile, but it is not sterile. The liquid fortifier, which is now more frequently used, I would say, it's extensively hydrolyzed bovine protein, and it's slightly higher in protein content than the powder fortifier, so that's another plus, and it is sterile. Some cons that we have to consider are that it does displace mother's own milk slightly by about 17%. And it is fairly high in osmolality, meaning we can't really add very much other supplements to safely stay within the osmolality that's recommended for enteral feeding. And then probably one of the most hotly debated topics right now in neonatology is human milk-derived fortifier. And this is donor milk that's essentially comes from a donor milk product that's pasteurized after rigorous testing of the milk, and it's tested for bacteria, viruses, and illicit drugs, nicotine, all of those things, and it's even matched with a milk DNA print to make sure that the donor is that the person who's donating the milk is actually that the milk was actually received from that person. So it's a really rigorous process in terms of safety profile, and that milk, that donor milk, is then pasteurized using the VAT pasteurization process. This is a slightly different process than what we use here in Canada at the milk banks, and the VAT pasteurization process does reduce the lactoferrin content a bit more than the Holder pasteurization process that we use here in Canada. So that's a con, I would say. The pasteurized milk is then concentrated to various caloric densities, and then the vitamins and minerals are added. Of course, the big pro of this is that it's a human protein source. The osmolality is really not a concern, and this product is also sterile. Definitely a con is that there's a high displacement of mother's own milk. So perhaps less of a concern in babies who receive mostly donor milk, but when we're talking about babies whose moms have an excellent milk supply, we are now displacing their milk with 20 to 40% of a donor or foreign product, really. And the second big con is that it is really, really expensive. So the million-dollar question is then, is one better than another? I know this has been previously discussed in this forum, so I won't go into the details about the literature itself, but I will say that expert bodies do not currently recommend one fortifier over another. There is emerging evidence to suggest that human milk-derived fortifier may reduce necrotizing enterocolitis, retinopathy of prematurity, and possibly late-onset sepsis. And there was a study, a meta-analysis that was done last year by Lucas et al. And he combined 3 studies and that contained roughly about 450 babies. And they did find a statistically significant reduction in NEC, ROP, and feeding intolerance. So I would say there's definitely emerging evidence for this, but so far we don't have large numbers yet. And I think some would argue that the cost at this point is quite high, and so we have to weigh the risks and benefits and take the literature all into consideration to make these decisions. And so this is a really hot topic right now. I'm going to shift away to the last part of my talk here to talk a little bit about how do we determine how many nutrients we should add to milk. And so we're going to talk about standard versus individualized fortification. So standard fortification is a process by which we add a standard amount of fortification to mom's milk. And really that's based on the average content of human milk that's been determined by, combining a lot of samples together and then calculating how much protein and how much fat is in that average sample. And then based on that, we're adding a standard amount of fortification to mom's milk. That being said, this is of course not individualized. And as I talked about earlier, each mom's milk has a different makeup and a different composition. So some babies, by using this method, some babies may get too much and some babies may get too little because we're adding the same to each mom's milk. It is still most commonly used, and it's very practical. But like I said, it doesn't consider the variations in milk composition between moms and even within mom. So is there a better way where we can use an individualized approach for each baby and fortify their feeds to what they might need? There's two ways or two approaches to this. The first one is an adjustable fortification. So essentially we're using a lab value, a blood urea nitrogen measurement twice a week. And if it falls within the target range, we assume that the baby is getting enough protein. If it's below the recommended range, then the baby may be getting too little, and so we can add more protein. And if it's above the recommended limit, then the baby may be getting too much, and we might decrease the amount of fortification that we provide. So this is quite a practical approach to it. The second way we can individualize fortification is by targeted fortification. So in this way, we would take mom's milk sample, we analyze it, and we determine how much protein, how much fat, how much carbohydrate is in the sample, and then we supplement based on that. So if mom's happens to have a low protein content in her milk, we would add additional protein up to the recommended dose. This is, of course, labor intensive and it requires breast milk analyzers, but this is certainly also a hot topic of discussion in the neonatal nutrition world at the moment. So take-home messages from my talk. So mother's own milk is a crucial medicine provided to preterm babies as it improves survival and it reduces complications associated with prematurity. Donor milk should be offered if mom's milk is not available. Ensure timely lactation support is in place and set clear expectations around all aspects related to pumping to optimize mother's own milk supply. And fortification of breast milk is necessary to provide adequate nutrition to support organ growth and development. So Fabiana, I'm more than happy to answer any questions.
Thank you so much, Dr. Rai, for your absolutely incredible presentation. I want to thank everyone participating. We have people from Kashmir, we have people from Zimbabwe. Actually, Francis from Zimbabwe said, what an educative discussion. Thank you, Francis, for joining us. I love having this international audience. It's really great to see so many people from around the world joining us. Dr. Ray, let's talk about fortification. That was your last in your presentation. So how soon do we start fortifying baby's milk? I mean,
that's a great question.
Baby.
Yeah, so I would say the sooner the better. Of course, we want to try and supply the optimal nutrients as soon as possible. And the best way to do that, of course, is enterally, so through the intestines rather than through an IV or through TPN. So generally speaking, we fortify around when a baby reaches about 80 to 100 mils per kilo per day of mom's breast milk. So once a baby can tolerate that, we try adding about half a dose of the fortification for about 48 hours and make sure the baby tolerates that. And then 48 hours later, we add that second half to it so that we're then fully fortified. The human milk fortifier, the company that makes that, they recommend fortification even earlier. And so that is another actually pro of that product, where the fortification can start as early as 40 to 60 mils per kilo per day. So yeah, right around that time.
That is incredible. So I think my question, a lot of parents always bring up those questions. Once we start fortifying the breast milk, they note the baby start having a little bit of reflux. Is this a common thing to happen with those babies?
It is very common, yes. So, it's hard to say, it does tend to happen around the time of fortification, but oftentimes I will say, babies who end up having persistent feeding intolerance, they had it even before they were fortified, and they continue to have it after they're fortified. And yeah, it is quite common. Like I said, it's the GI tract is very immature still, and so it's not supposed to see nutrition yet. It's not supposed to be all of a sudden digesting things and starting to absorb them. So it takes a bit of time as the GI system adapts to that, and so we call that feeding intolerance. And so sometimes it's manifests in the form of having some spit ups. Sometimes the baby is quote unquote gassy. So there's different ways in which that can manifest itself.
Okay, so when baby's getting closer to going home, and obviously you want the babies on a full feeds and all the good stuff to make sure the baby is growing and is healthy going home. Why some babies still have to have fortification on the transition into home? And I'm sure Karen Lasby, our next speaker, is going to address that, but I want to thank you for the last few weeks of the NICU leading to going home.
It's all about growth. So the brain development, and I was going to add it to my slides, but I thought it was going to be too long. But the thing that we focus on the most is really providing adequate nutrition to make babies grow the way they would have if they had still been in their mommy's tummy. So if babies are falling behind, despite what we do in the NICU, it's possible that they need to stay on those extra nutrients to try and at least maintain or even do some catch-up growth. After they go home. And so that's not uncommon.
Okay, so we have another great question here from Mena. When would you add the probiotics and what complications might occur?
Oh, that's a great question. So I am in Canada, where we have very strict health regulations around the probiotic products. So it's very rigorous around safety of those products. So complications, I guess I'm starting by the end of that, answering the last part of that question. The complications theoretically are that there may be contamination of those products, and babies may get infections from them. There is a few case reports out there in the literature when you look. However, it's extremely, extremely rare, and by far the benefits of probiotics outweigh the risks of that. Like I said, in Canada, where we have very strict regulations around those products, I have not come across a case report in Canada because of that. We start probiotics, like I said, the microbiome starts to develop right after birth. And so we start probiotics as soon as the baby is ready to have its first feed. So it started with the first feeding.
Wow, that's very early.
Yeah, it's very early, and we continue them on even after babies are transferred to a level 2 unit, or even after they go home. Parents oftentimes will say, "Hey, where can I get this?" And you can actually just buy it at the pharmacy, at the grocery store.
Dr. Wright, one question that I have in relations to oral immunotherapy, because after your Karen last session today, I talked to a doctor from Japan who said the smallest baby, 268 grams, and he started doing OIT on day 1 of life. So what is your take on that? And is this a common practice in Canada now?
Absolutely. So OIT is incredibly important. So this is where we take that colostrum that's really, really high in the immunoprotective components that we want to coat the baby's intestinal tract with. Sorry, we have a visitor in the background. So we coat the baby's intestines with that. So that colostrum is incredibly important. The immunoprotective factors are absorbed in the baby's mouth. So as soon as we have any drops from mom, we apply that into the baby's mouth. Ideally, the mom does it herself if she's able to come and visit her baby already. But as soon as we have some, the support person or partner comes over and we put it right into the baby's mouth right as soon as possible.
Okay, let's talk about colostrum, because we always know this is the liquid gold, and this is so important for babies. Talk a little bit about colostrum to just remind everyone how important that is.
So the colostrum is the very first milk that's produced by mom. It's that yellowy colored that I showed you in one of the pictures, and it's kind of thick and mucousy, and really it is just so full of those antibodies and immunoprotective and growth factors that are really so important to first get into the baby to start, maturing or coating really the gastrointestinal tract of the baby. So all of those important nutrients are absorbed right, like as soon as you put it into the baby's mouth. So the colostrum, although it looks like, oh, I've only gotten 1 or 2 drops of breast milk, we want moms to bring it over. It's that important. So yeah, I hope I've emphasized that enough. So before that milk transitions, any drop of colostrum we can get our hands on, we want to take it.
So we have another question from our live audience. Nina asks, are anti-reflux meds successful in reducing reflux in preemies? Thank you, Nina, for your question.
Great question. And we get this a lot, right? It goes hand in hand with that question about, oh shoot, I'm losing my train of thought. Feeding intolerance. Yes, that's what it was. So I think, here's the thing. Most babies have some form of reflux. It's part of their immaturity of their GI system. That sphincter that keeps all of their food into their tummy is also not super tight yet, that big muscle. And so it's easy for milk to come and reflux back up. Sometimes it can be significant enough where babies are not retaining enough of their milk. And so in those instances where we see poor growth secondary to reflux, or we are attributing it to reflux, we may try anti-reflux medications. But in general, if a baby is growing well and does not appear to be uncomfortable, or it doesn't impair oral feeding once they get a little bit bigger and they're able to start working on oral feeding, we tend to not treat with anti-reflux medications because there's always side effects to reflux medications.
Okay, so we have another question here from Nina, but I believe a pediatrician can guide her on that direction. But my 32-week preemie is being prescribed anti-reflux medication as the reflux is believed to be causing O2 desaturation. After we finish the 8-week treatment, should the episode stop?
So reflux is believed to be caused by... After we finish the 8-week treatment, should the episode stop? So, I mean, usually speaking, maybe I should just back up. So anti-reflux medications, depending on what is being prescribed. So there's really 2 types. One is what we call a pro-motility agent that essentially starts to move things down in the GI tract, so less of it can come up. The second type of medication is an antacid. So it reduces the acidity of the stomach contents so that it causes less painful sensation in the baby's esophagus. So like I said, so if you are using the one that moves things along, you should see improvement in your oxygen saturations, right? Because less is coming up, causing those desaturations. If she's been prescribed an antacid, the same amount of milk will still come up. It might be less acidic and less irritating, but it shouldn't actually have an impact on your O2 saturation. So it really depends on which medication was prescribed. And if it's a combination of things, then you should see a benefit. But usually we tend to try a baby on it for a couple of weeks before we can say, yes, it worked, no, it didn't work. Absolutely. So that 2-week mark is sort of where you can make a determination.
Okay, Dr. Wright, our time is almost up, but I have one last question for you. In early pumping, we know how important it is, and a lot of parents have expressed with us their concern. They are not being very supported in pumping at this time with COVID. There is less support for pumping and breastfeeding. So I think I would like to hear from you how important it is to early pumping, as you mentioned before, and the continue the support during the NICU stay.
Yeah, early pumping is absolutely, it is the most important thing. Like I said, it's very clear from the evidence from the literature that early pumping, meaning less than an hour even, the earlier the better. And that really predicts the milk supply that the mom will have throughout her lactation journey. So that might be a few months, or it might be 6 months, or even up to a year. So those first 2 weeks are absolutely critical. The earlier you start, the better. It's difficult with COVID. I'm very grateful that in our center, we've been able, our lactation consultants are there. They are essential. They are able to provide the support that they were before COVID. And I think during this time, healthcare professionals in centers where that might not be the case, it's really upon us to touch base and do some of that counseling with mom. And I think nursing support is really important from that aspect as well.
Absolutely. Dr. Ray, thanks so much for joining us here today. It was a great presentation. I'm very grateful that you took the time to share your knowledge with us today.
Oh, thank you, Fabiana. Looking forward to the next few talks.
Yeah, thank you. And thank you all of you for joining us here today live on Facebook and YouTube channel. We'll be back in just a few minutes with Karen Lasby, talking about feeding after discharge. And then we're going to have Dr. Takeshi Arimitsu talk about the chances and challenges in tiny babies. I want to thank our sponsors, Medela, Water Wipes, and Prolacta for their ongoing support. And CPBF is a registered charity, and 100% of all donations received this week will go to our support programs for families. To donate, please go to the Canadian preemies.org and stay tuned. You'll be back in just a few minutes. Thank you.